My name is Dr. James Tumlin. I'm a nephrologist and a professor of medicine with Emory University here in Atlanta. I'm also the founder and director of the NephroNet Clinical Trials Consortium. And so I'm going to give you my opinion on the immunologic basis of the pathogenesis of IgA nephropathy and how that's going to impact all of us in the way that we care for our patients moving forward. Because of the pathogenesis and the clinical manifestations of IgA nephropathy, namely that there is progressive loss of renal function over time, invariably there is varying degrees of amount of proteinuria as well as hematuria. And both proteinuria and hematuria have been correlated with poor outcomes in these patients. A fundamental shift that has occurred in the global approach to IgA is an understanding that we may have had it wrong in the past. That in fact, previous numbers where we assumed that if you were under 1,000 milligrams of protein a day were sufficient control were probably not correct. So the diagnosis of IgA nephropathy, by definition, has to be done by renal biopsy. And there's been recent studies looked at the age at which people receive a biopsy and what their GFR was. GFR stands for glomerular filtration rate. And this is a numerical function of how well the kidneys are doing in their job of clearing toxins. The majority of these people are young. Many of them are in their 20s and 30s. And so if you have, like what we talked about earlier, a loss of GFR of 5 to 7 mils per minute per year, if you're a 25-year-old young person, at that rate of renal function, you could wind up on dialysis within your late 40s or early 50s. So the long view of this is extremely important. And moreover, I think all of the nephrology community needs to sort of reset, reboot, if you will. We can't be pleased with a GFR that's losing between 5 and 6 mils per minute per year. We need to get that GFR loss to as flat a slope as we possibly can. So with regard to treating IgA nephropathy, there had been very few options that had general consensus and agreed upon. Clearly, based on the KDIGO guidelines and other recommendations, the RAS blockade is very important. So tight control of blood pressure is clearly a benefit in slowing the progression of renal disease, and specifically using RAS blockaders, ACEs or ARBs. It should be emphasized that even with that type of therapy, there is still a progression patients toward end-stage renal disease. More recently, there's been some studies using the SGLT2 antagonist, and they have become widely used in IgA nephropathy, and they clearly have benefit. But I think it would emphasize to the audience that the complexity of the pathogenesis indicates that there are many other and more directed pathways that we can use to treat this disorder. There are some patients, typically young people, oftentimes they're in university classes and they'll get a viral infection, they'll develop an episode of gross hematuria. But when you look at those young people in between these episodes of gross hematuria, they generally don't have intermittent low-grade hematuria. Those individuals do quite well and have very low levels of progression. In contrast, people that have intercurrent hematuria with proteinuria do much worse. In fact, a seminal series of papers that coming out of the UK called the RADAR trial has demonstrated almost, if you will, a dose-dependent effect of proteinuria on outcomes. For example, even with the seemingly innocuous level of 440 to roughly 500 milligrams of protein for 24 hours, those individuals, when followed out and amortized over a long period of time, have upwards to a 10% chance of progression of end-stage renal disease. If you take that number to above 1,000, which I would remind the audience was what was considered to be standard of care and proper therapy as little as 10 years ago, those people have upwards to a doubling or a 20% chance of end-stage renal disease at 5 years. So I think it's very important that we do the typical things that we do to reduce proteinuria, ACE, ARB, and those kind of pathways, but also to slow the progression of renal disease and prevent dialysis. This is principally a B-cell functioning disease. And the process of B-cell maturation, when going from a pre-B-cell through and all the way down to a plasma cell, and under the regulation of two principal and very important cytokine pathways called the APRIL pathway and the BAFF pathway. So these are broad generalizations. There's a lot of overlap between the two different cytokine pathways, but for purposes of this discussion, APRIL is a cytokine that directs a beta lymphocyte toward what we refer to as class switch. So it instructs the B cell to either become an IgG B cell, an IgM B cell, or an IgA B cell. The BAFF pathway, which works in concert with APRIL, and I should emphasize there's a fair amount of redundancy between the two pathways. BAFF primarily tells the B cell to mature and proliferate and ultimately move down toward the pathogenesis of becoming a plasma cell. In preclinical animal model studies, whenever you stimulate or hyperstimulate these pathways, you can often get a glomerular disease that resembles human IgA. And this indirectly tells us the importance of these pathways in the pathogenesis of IgA nephropathy. That elevated levels and persistent elevation of Gd-IgA1 leads to and propagates IgA nephropathy, then it does make sense therapeutically to block a pathway through, for example, say BAFF, that leads to maturation of B cells to long-term production of plasma cells. And so preventing that process, from my mind, seems to make a lot of sense. Plasma cells that make Gd deficient IgA1 live for a long time. And studies are very clear that in patients that have higher levels of gal deficient IgA1 have a worse prognosis. And so animal models and other studies that have shown the ability to knock down the gal deficient IgA1 leads to less inflammation and damage to the kidney over time.